Assalamu alaikum. Uh, Today's topic of presentation is donor nephrectomy. My moderator is Dr. Abdul Khalik. I am Dr. Hamadullah. Kidney transplantation has been the definitive treatment for end-stage renal disease for last 70 years. The objectives of today's presentation is to know about the approach, the surgical steps, the concept of ischemia time, and about the bench dissection during donor nephrectomy. The principles of surgery are adequate exposure, careful handling of tissues, especially during periarterial dissection to limit the vascular spasm, and preservation of adequate perihilar and periureteral fat to ensure the adequate vascularity and to limit the possibility of subsequent ureteral necrosis. The maintenance of active diuresis that makes the prompt post-transplantation function more likely.
So I would like to emphasize these principles are quite important. The technically the donor nephrectomy is surgically an easy task, but it's more stressful because in our center we are doing live related renal transplantation. There is no margin of error in this surgery. And the important thing is to ensure that there is minimal handling of the kidney. So usually we go supra 11 so that we have a good exposure to the kidney, and we can have minimal handling of the kidney and the vessel, so that there is minimal chance of arterial spasms there. And same principle goes for the ureter as well. The ureter is mobilized along with its mesentery, so that there is less chance of stenosis or leakage as well. We have seen ureteric anastomosis leakage as well due to ischemia. So the last principle is active diuresis. The one who has been posted in the transplant theater should have seen that we usually apply clamp to the artery when we have collected a bit of sample. It's not a bookish thing to collect 30 cc or 50 cc sample, but the main purpose behind it is to just make it sure that the kidney is actively making urine, so that if it is sort of guarantee that we have done the donor nephrectomy in the right way, because the kidney is making urine. If God forbid something happen in the recipient and there is no urine output in the recipient, so probably there is something related to the recipient factors, not up to the donor.
The surgical approaches are open donor nephrectomy, uh, an endoscopic living donor nephrectomy, which includes pure or hand assisted transperitoneal laparoscopy, pure or hand assisted retroperitoneal approach, laparoendoscopic single site surgery, and natural orifice transluminal endoscopic surgery assisted, robotic assisted transperitoneal or retroperitoneal approaches. We at our center usually perform open donor nephrectomy. Uh, Open donor nephrectomy should be considered to avoid the acute renal compromise related to pneumoperitoneum and warm ischemia, which may occur during laparoscopic donor nephrectomy. And if there is prior history of extensive transabdominal surgery, which makes the laparoscopic donor nephrectomy difficult. And if there is a short renal vein, the length equal to 1.5 or less than 1.5 centimeter, or in right-sided kidneys, if the extra 5 to 10 of renal vein is felt to be required. The right-sided donor nephrectomies are technically more difficult because of short right renal vein. Finally, any circumstance in the donor or recipient that seems to be a potential source of technical compromise that would be more optimized by open procurement should be considered. For example, in a donor who is a patient of COPD, in whom the pneumoperitoneum cannot be created, or when created may cause complications. The surgical steps of open donor nephrectomy, the incision, the position is classic flank position, and the Foley place. After placing Foley's, the patient is positioned in the classic flank position. The downside is supported by the kidney rest of the table, and then the table is flexed and placed in slight Trendelenburg position until the flank is parallel to the floor. A roll is placed in the downside axilla to prevent the brachial plexus injury, and legs are appropriately padded. Skin incision may be supra 11 or supra 12 rib incision, or and the total incision should be no more than 15 to 18 centimeter.
So the positioning of the patient is quite important because it will not only help you in the surgery, but it is also important for the safety of the patient as well. Because if there is some malpositioning of the patient, we have seen patient with the wrist drop and other brachial plexus injuries as well. So it's important to consider the padding points where should we should apply pads, and so there are pressure points. Yes, Samar.
So the pressure areas or the pressure areas like the bony prominences and the axilla to prevent the brachial plexus injury should be padded. So the after incising the skin, the subcutaneous fat and muscles are divided. Muscles include external oblique muscle and internal oblique muscle, and transversus abdominis anteriorly, and the latissimus dorsi and serratus posteriorly. Uh, the retroperitoneum is entered and diaphragm and pleura are saved. Uh, the retroperitoneum is dissected using blunt and sharp dissection, and the ureter is identified with surrounding tissue down to the level of ipsilateral iliac vessels. This is important to prevent ureteral ischemia. The ureter is not divided until later in the case. The Girota's fascia is entered and the kidney is mobilized all around. So the adrenal gland is spared on left side. If we are doing left donor nephrectomy, adrenal vein is ligated and divided between 40 silk ties. Mm, Similarly, on while doing left donor nephrectomy, the gonadal vein is identified and ligated. Ureter should be mobilized along with periureteric fat. Uh, the hilar dissection of the renal vein is then carried out. Any lumbar veins originating from the renal vein are controlled using clips or permanent sutures. The right renal artery is usually in a retrocaval position. An additional length may be achieved by dissecting laterally and behind the inferior vena cava.
So the gonadal vein is an important landmark while doing donor nephrectomy on the left side. It helps you trace to the renal vein. While on the right side, gonadal, we all know the gonadal vein drains directly into the IVC. So it's a bit different on donor nephrectomy is a bit different on the right and left side. While on doing on the left side, you go for gonadal vein and adrenal vein first, so that you can have a good length of the vein and you can mobilize the renal vein. On the right side, there is no need to tie gonadal vein if it's not coming under your clamp.
So after confirmation with the recipient area, the ureter can be divided. As much length as possible should be preserved, and the golden triangle should be saved. The golden triangle represents the territory of ureteral vasculature, and it should be secured. And the boundaries include lower pole of the kidney and the joining of the renal vein into the inferior vena cava, and includes the gonadal vein as well. The renal artery is controlled with a right angle clamp and divided as close to aorta as feasible, ensuring adequate space to permanently control the stump. Also, on the right side, the renal vein is usually short, so we take adjacent portion of IVC along with renal vein on right side. On left side, the renal vein can be clamped over the medial aspect of aorta to ensure a good length of vein. Using a scissor, the vein is divided, including a cuff of IVC with the donor kidney on right side. The inclusion of the IVC cuff is a distinct advantage of open technique for the right side.
There are different ways to secure the renal artery, or one way is to apply the right angle clamp and just cut a few millimeter above it, and the other way is to just tie a silk knot and apply a liga clip and cut the artery. While doing the applying clamp on the right side, a cuff of IVC is been taken along so that we can have a good a bit extra length of right renal vein, as well as not additional length is gained, but also it's important that you anastomose that patch of IVC with the common iliac vein, because the intima or the quality of tissue the right renal vein is not so good. There's more chance that your stitch can get cut through, and there's more chance of bleeding. So it's technically more easy or more secure. The anastomosis is if we do anastomosis between the patch of IVC and the common iliac vein.
Thank you, sir. So the kidney is the renal artery is ligated with a zero silk free ligature and a large caliber polypropylene suture ligature. The renal vein is oversewn with a continuous 40 propylene suture, and the closure of flank incision is done layer wise using PDS or vital sutures. The skin is then approximated. The diagram shows the golden triangle, which signifies the territory of ureteral vasculature, and it should be ureter should be mobilized along with periuteric fat to ensure proper ureteral vasculature. So
Second, we are going to apply clamps. Clamps of apply the lecture. आइडिया किसी को कोई आइडिया है कि when we are ligating artery तो हमें when we apply a clamp and when to ligate it and remove the kidney.
When finally we have mobilized the kidney, ligated the ureter also, and we are in a position to take off the kidney, then we'll apply the clamps. And
The question is when to apply a clamp and when to ligate it and cut it. Is it necessary always you need to apply a clamp and then remove the kidney, or you need to just ligate a silk suture and cut the artery and remove the kidney? So in a patient who has got an early division, usually early division from the aorta, and you need to take a single stump of an artery. So where you will not be able to apply a clamp, because when you apply a clamp, there is a loss of 3 mm of the artery, and you need to ligate it below the clamp. So in that patient, you need to apply a silk suture and you cut it just above the suture and apply a lega clip below the your suture line. So you will be able to take a single stump so that you will not be needed to make a single stump at the bench. So you will reduce the cold ischemia time in that patient.
But because when we apply the right triangle clamp, the 3 millimeter of length of artery is being lost and is being crushed between that in between that clamp. So when you think the length of the vessel or the point that Dr. Abdul Khalik emphasized is considerable, then you try to just save that 3 millimeter as well. So in that scenario, you ligate with the silk suture.
So the images show donor nephrectomy steps of donor nephrectomy performed on while doing right donor nephrectomy. So exposure of the kidneys with mobilization of the ureter, as you can see in the first image, and then after complete mobilization and clamping and dividing the ureter, and after confirmation with the recipient area that everything is okay with recipient, then you can clamp the renal vessels and deliver the kidney for bench dissection. And on right side, after removing an IVC patch, the primary repair of IVC is performed. While on as you can see in images on left side, the kidney is exposed and the gonadal vein and ureter can be seen in the first image. After that, it can be traced up to identify the renal vein, and the renal hilar dissection can be done, and then at the end securing the renal vessels with clamps and dividing and delivering the kidney for bench dissection. So there are two main reasons of kidney graft injury. The one is ischemia, and the other is reperfusion injury. Ischemic injury and the reperfusion injury. So ischemia is divided into warm and cold ischemia, and the ischemia is defined as.
Can anybody explain about what is warm ischemia and what is cold ischemia? Yes, Arslan. The warm ischemia comes first.
uh, clamp clamping of vessels, and it's not
Vessels.
renal artery, and it's basically not more than 20 minutes. And in var ischemia is also defined as a time duration from uh, removal of graft from cold storage till the restart of the reperfusion of the warm blood as well.
So कोई और बताएगा थोड़ा अच्छी तरह एक्सप्लेन करके. Yes. Yes. Before dividing it.
The time when we clamp, warm ischemia is the time when we clamp the renal artery till the transfer of the graft to the on the bench, and the cold ischemia is the time till we do whole bench dissection and transfer the kidney
Till the
to
transfer क्या मतलब
the
हुआ?
recipient.
Till the transfer के आपने ट्रांसफर
Yeah.
करके छोड़ दिया बस वो चलता रहेगा या खत्म हो
No, no, no. Warm ischemia is basically the time when we clamp the renal artery and then transfer it to the on the bench over the tray, ice
जाएगा?
tray.
ट्रे हो गया. कोई और बताएगा?
Basically, when we do circulatory arrest, till we transfer the kidney for cold ischemia,
What is the cold ischemia time?
for bench rest. Period of
Okay, so it's warm ischemia time is basically the time that starts from the clamp of the artery till the start of perfusion. So you start with the perfusion solution at the bench dissection. So this should be minimized as less as possible. Ideally, it should not be more than 3 minutes, but it should be as less as possible within seconds or 1 or 2 minutes. And the cold ischemia time starts once you started the perfusion and you anastomose with the recipient and remove the clamp. Once you remove the clamp, then your cold ischemia time is finished. And the cold ischemia time can be extended up to 72 hours if you keep it in a cold perfusion area. So, but the warm ischemia time cannot be extended more than 3 minutes in live related, particularly. 20 minutes is written in the books, but in live related transplant, ideally it should be as less as possible. It's not an extended time to 20, 30, 10 minutes.
So ischemia is the diminished blood supply to any tissue or organ of the body, causing a shortage of oxygen. And it in donor nephrectomy or in transplant, it is divided into cold and warm ischemia. So the total ischemia time is the time the kidney is removed from circulation. And in live related renal transplant, it is rarely longer than 1 hour, while in cadaveric renal transplantation, kidneys are ideally transplanted by 24 to 36 hours, but there are reports of successful renal transplantation up to 72 hours. The cold ischemia time is the period of cold storage or machine perfusion. It is single most important risk factor for delayed graft failure. The warm ischemia time is the time between circulatory arrest or aortic cross clamping in the donor and cold perfusion, and the cold perfusion is commenced on the table. Ideally, this should be zero. The rates of delayed function increases markedly with increased warm ischemia time. Re-warm ischemia time is the time from the removal of a kidney from cold storage or perfusion to the beginning of reperfusion after the completion of renal arterial anastomosis in the recipient. and the reperfusion injury after anasmosing the kidney, the graft in the recipient. When we remove the clamps, the blood flow which was previously not there, it causes paradoxical exacerbation of cellular dysfunction and death. uh, this is usually due to the reactive oxygen species. So we have different kidney storage solutions, and the aim of modern kidney storage solutions include the minimization of oxidative reperfusion injury, and the control of cell swelling during hypothermic ischemia, and the maintenance of intra and extracellular electrolytes during ischemia, and the buffering of acidosis and provision of energy reserves.
Can anyone name the solutions? कोई solutions के नाम पता है किसी?
So different storage solutions are Eurocollins, or this is not used in today's time. HTK, histidine, tryptophan, ketoglutarate solution, and University of Wisconsin solution, Celsior, and Marshall's hypertonic colloidal solutions. And in live related renal transplantation, only crystallite solutions can also be used as perfusion solutions, storage solutions. HTK has low viscosity and low potassium concentration, and it's low cost. Guidelines recommend that you should use University of Wisconsin solutions, and if it is not present, we can use HTK solution. Uh, This is the composition of University of Wisconsin solution compared with HTK solution. As you can see, these have different electrolyte gradients and then antioxidants. The antioxidants include glutathione in cases of University of Wisconsin solution, and tryptophan or glutarate or mannitol in HTK solutions. So the use either University of Wisconsin or histidine, tryptophan, ketoglutarate preservation solutions for cold storage, or use Celsior or Marshall solution for cold storage if UW or HTK solutions are not available. So uh, we will discuss laparoscopic donor nephrectomy. We will discuss left side laparoscopic donor nephrectomy mainly. We have a video of our own institute, but it is of right side donor nephrectomy. We will show it in between. So the advantages of laparoscopic donor nephrectomy are decreased post-operative pain, improved cosmesis, and shorter convalescent period, and equivalent graft function compared to open donor nephrectomy. So the pre-operative assessment includes the same as open donor nephrectomy. Multiplicity of renal vessels or anomalous renal vasculature are not the contraindications, and CT angiogram with three-dimensional reconstruction should be done as we do in open donor nephrectomy. The DMSA or DTP or MAG3 scans can be done to know about the differential renal functions. So, patient is marked with a 5 to 7 centimeter Fenton steel incision, uh, modified right lateral decubitus position, 45 to 60 degrees, with the flank situated over the kidney rest. And the table is flexed to increase the area between iliac crest and costal margins. A beanbag or large gel rolls are used to support the patient in this position. Pillows are placed between the legs, and the right leg is flexed at the knee while the left leg is placed straight. The arms are placed parallel onto well-padded arm boards, and the ankle, knees, hip, dependent hip, and the shoulders and brachial plexus are adequately padded. After verifying that all areas prone to pressure injury are well padded, the patient is secured to operating table using 3 cloth tapes across the left shoulder and arm as well as across the hips. So the ports include. So this is the image of a donor nephrectomy performed here as at SIOT. The port placement, as you can, there are different ways of port placement. As you can see in this image, the camera port is at the lateral border of rectus muscle. This is the image of left donor nephrectomy. So the camera port is at the lateral border of rectus muscle, and the two primary working ports, one in the mid mid clavicular line below the costal margin, and the one in anterior axillary line, 3 to 4 fingers beneath the costal margins, and the lower ones, as you can see, these ones are assistant ports. These are joined or combined later in the case to deliver the graft. Other ways of port insertion are 5 or 10 trocar is inserted under the direct vision at the umbilicus, and the primary camera trocar, which is 5 to 10 is placed slightly left of the midline. The primary working trocar, 12 is placed along the mid clavicular line and 2 centimeter below the level of umbilicus. An accessory trocar, which is 5 may be placed along the anterior axillary line approximately 2 centimeter below the costal margin, and a 0 or 30-degree laparoscope is used throughout the procedure. So the steps include.
Hamad, you can go to the video.
Okay. So this is the video of right-sided donor nephrectomy performed at SIUT. It's an old video and not much clear, but so the pneumoperitoneum has been created, and the colon has been mobilized already along the white line of Tolt, exposing the proper plane between the colonic mesentery and the renal hilum, Girota's fascia. Sorry. So the right-sided laparoscopic donor nephrectomy is technically more demanding due to the short right renal vein, and the hilar dissection should be done with meticulously, and the tissue planes should be respected to limit the arterial spasm and to limit the proper plane between the colonic mesentery and Girota's fascia is important to know, so that we don't create a mesenteric defect or future internal herniation. Renal vessels are identified.
Actually, this is hand-assisted donor nephrectomy, in which uh, the port placement we have already seen The lower two assistant ports are joined at the end to introduce a hand, in which we have wear gloves and a wet gauze piece around, so that there is minimal chance of air leakage as well. So the assisted hand is introduced into the belly or tummy, and kidney is just lifted when we have mobilized the all of the vessels. Ureter is being already been cut, so this is probably hand reduced. We can see that the step and the vascular stapler has been introduced, and it will be fired on the renal artery. The it just not only secures but also cuts the, so the artery has been transected or divided. The same another stapler is used for the vein, and that assistant whose hand is inside the abdomen, he just grabs the kidney and gives it to the for the bench dissection. We have Dr. Asad along with us. We would like to have his input regarding these hand-assisted donor nephrectomies. It was done way back, but probably he will be remembering it.
It's not a way back, but चलें उसको हम छोड़ देते हैं. Normally, this was the high point when our laparoscopic service reached to this point when we used to do regularly almost all donor nephrectomies, whether right side or left side, and it was totally laparoscopic nephrectomy. It wasn't a hand-assisted nephrectomy till the very last moment when you want to retrieve the kidney. Why the hand was placed? Just because the reason that we want to cut short the cost of retrieval bag. Now that costs around $100 at that time. I'm talking about 2018, 19, 20. So it was a little bit costly for us to spend that much of money, and it was it didn't give us any kind of advantage. So we thought of putting the hand in, and the kidney rests on the palm of the hand, and the hand should be, for instance, if you are doing it on the right side, that is right donor nephrectomy, then the assistant hand should be the right hand, so that the body should not obstruct the operator. The same happens with the left kidney. If you are doing the donor nephrectomy, the assistant left hand should go in rather than the right hand, so that the body should be in parallel with the operator's body. So in that way, you must know, or you must be cognizant of the fact that you design your team accordingly so that nobody obstructs nobody, right? The second point is, when the kidney rests on the palm, the vessels run through the web space between the fingers, as is shown in the last a bit of this video, this point. I mean, in this, if you just zoom in, you can see that the kidney rests on the palmar surface of the hand, and between the fingers, the vessels are going down. So the vessels are not being touched completely, and it gives you a little bit of a pull. You shouldn't pull it much because that would lead to intimal tear. So there is a very fine balance how much it has to be pulled up, and then the operator, the main surgeon, puts in the ligashore so that the vessels are being taken down. Artery first and vein next, and that has got a logic, because if you do the other way around, for instance, you do vein first and artery next, the kidney would become filled up with blood, and it becomes dusky in color, not dusky, but rather reddish in color, hyperemic, and it would lead to hemorrhages. So it is a logic that you must put in clamp on the artery first and vein next. So this is how the whole thing is done. And once the thing is, the vessels are clipped, that is, they are taken down, the hand has got the kidney in its palmar aspect. It pulls the kidney through the knee, through the hole which has already been created in the abdominal wall, and is taken very fast to the back bench. Why I'm telling you? Because we want to cut short the ischemia period, and this is the warm ischemia period. Now, this warm ischemia period theoretically is longer in laparoscopy as compared to open donor nephrectomy. But if you work your team day in and day out, and everybody knows what to do and when to do and how to do, then you can minimize all these steps in terms of time, so that lesser time is taken by this whole maneuver, and you reduce your ischemia time, the warm ischemia time, to 2.5 minutes. So on an average, our ischemia time ran through 2.5 to 3 minutes in laparoscopic donor nephrectomies, whether it is right or left. So that was the high point of our laparoscopic service into 2020, till 2020. But then came robot, and everything was taken up by the robot. The rest is history.
So the kidney is delivered for the bench dissection. Uh, a kidney graft from a living donor by an open technique requires little preparation before transplant by recipient team, because presence of significant amount of perirenal fat, stapler lines, and retraction of the renal vein into the renal hilum, or the presence of multiple vessels. Significantly more bench work is required for kidneys removed laparoscopically. Artery and vein removal of the stable lines and rapid flushing of the kidney with ice cold preservation solution, as we have discussed, is the initial priority, followed by the final dissection. The kidneys from the living donors are selected preferentially to have a single
I
artery.
think all these points have been explained by my commentary. But just one point, because earlier there was a discussion. What is the difference between warm ischemia time and cold ischemia time? Very simple. If you start perfusion through a perfusion fluid, which is a cold solution, then your ischemia time enters into cold ischemia. Now, before that, everything is warm ischemia. And once that solution is stopped running through the vessel, running through the kidneys, then again the warm ischemia comes in. So the warm ischemia comes in many phases, rather than it is something which goes off and something which comes on. So you can have warm ischemia in the early part of bench dissection, in the later part of bench dissection, but in the middle, when the perfusion fluid is running through the kidney, it is a cold ischemia. The second point is, for instance, you can increase this cold ischemia time by having a machine perfusion. You haven't seen machine perfusion, but I can draw the diagram and give you a little bit of detail, because I think Murli also knows it, and I also know it. We have been having donor kidneys from Eurotransplant program, and this kidney, it has to flow. It has to just fly to our country from Europe, from Netherlands, in a box which has got oxygen around the kidney, and there is a compressor and a pump built in, which pushes through this cold solution through the vessel into the kidney and goes out. So it's a very marvelous kind of engineering model. So that makes the kidney viable up to 90 hours. So 90 hours is machine perfusion. Yes. So that was enough time for any kidney to work, or to fly around the world, anywhere from one point to the other point.
I think our one kidney is 72 hours ischemia time. So I think, transplanted 24 kidneys. We received 24 such kidneys from one transplant.
Uh, yes.
You can go to the video once.
So what we do in a bench dissection, here you can see the kidney. Yes. Hello. It's a very short video that you can see these. We are taking sutures at the vein. Actually, this is a bench dissection of a patient with a double renal arteries, and we removed the two arteries and the one renal vein, and we just dissected out the artery and the vein, separated both the arteries and the vein, and then we have planned to make a double barrel anastomosis. We join both the arteries in a side to side manner to make a single lumen to be anastomosed with the recipient artery. Continue, Guru. And here you can see the artery and the vein is being manipulated, and all the surrounding small vessels and the lymphatics are being ligated so that there should not be any leakage, and then we defat the kidney to remove the extra fat. Because why we remove the fat? Is it necessary? निकालना चाहिए या नहीं निकालना चाहिए? Fat is basically immunogenic, so we can keep the fat at the hilum where there are chances of vascular injury, but the extra fat should be removed because this is immunogenic and the patient will have consequences in the future.
Thank you very much.
Thank you, sir.